Okay. Hi, we're waiting for folks to start coming in and then we're going to get started. So hi and welcome to this afternoon's webinar. Just give it one more minute as folks are coming in. Welcome, everyone. Okay, so hi, everyone. I'm Lori Smetanka. I'm Executive Director of the Consumer Voice, and welcome to this afternoon's webinar, Using Data to Protect Nursing Home Residents. We are glad to have all of you here today. For those of you who are not as familiar with the Consumer Voice, we are a national nonprofit advocacy organization. And Libby, if you could go to the next slide. We work with and on behalf of individuals receiving long-term care and services. And through our work, we advocate for public policies that support quality care and quality of life that's responsive to consumers' needs. We work to empower and educate residents, consumers, and families with the knowledge and tools they need to self-advocate so that they have the information and resources they need to be their own best advocates. We work to train and support individuals and groups, citizen advocates, long-term care ombudsmen, and others that empower and advocate for consumers. And we promote the critical role of direct care workers and best practices in quality care delivery. We are thrilled to offer this webinar to you this afternoon. A few housekeeping items. You may have heard at the beginning that this webinar is being recorded. And the recording as well as the slides will be available on the Consumer Voice website. Afterwards, the slides also will have a link in the chat, so you can download them from there if you'd like to follow along on your own. We do ask that you use the Q&A feature on your control panel if you have questions for the speakers, and we will take as many questions as we can at the end of the program. We're going to go through all of the presentations first, and if we have time at the end, we'll get to some questions. If you can use the chat feature to submit comments or respond to questions or to just chat among yourselves, or if you're having any technical difficulties, you can put those in the chat, but please put your questions for the speakers in the Q&A. We do ask that you complete the evaluation questionnaire when the webinar is over. That'll pop up on your screen when the webinar finishes. And as I mentioned, links to the resources will be available from the Consumer Voice website. So again, thanks so much for everyone being with us today. We've got a great group of speakers today. We've got Sam Brooks, who's our Director of Public Policy at Consumer Voice. Many of you know Charlene Harrington, who is Professor Emerita at the University of California, San Francisco, and has been a longtime friend and guest speaker on a number of webinars that we've held here at Consumer Voice. And you know Charlene from her expertise on staffing and facility finances. We've got Eric Goldwine, who's Director of Policy and Communications at the Long-Term Care Community Coalition, who we're thrilled to have with us today. And also our friend Ann Montgomery, who's a senior analyst with the National Committee to Preserve Social Security and Medicare. And we've worked with Ann for a long time in various roles that she's had, including when she was on the Hill. So we're thrilled to have these folks with us today. As we have been doing some advocacy together as a group and with some other partners, we have been talking a lot about data and the use of data and how it can be used in a manner not only to be transparent in terms of letting people know information about what's going on in long-term care facilities, not only with respect to quality, but also with respect to how money is being spent and what's happening with residents. But it also is able to be used for accountability purposes in terms of holding individual providers accountable for the care that they're providing, for how they use the resources, the public money that they get and are supposed to be using to care for the people in their charge. But also it can be used not just for individual providers, but across corporations and chains and multi-owned multi-owner facilities and owners that own multiple facilities. And obviously, I know you can understand the distinction there. The data can be used for an accountability measure there as well. And what we have seen is that it's not always being used for those purposes. And also using the data is a preventive tool in terms of being able to work to get ahead of bad care practices, for example, or people that are not um, owners that are not putting the necessary resources into facilities or are not ensuring that facilities are providing good quality care. It can be used in a preventive way. So data is really important. We're getting more and more of it that's available. And there's a lot of good data that is already out there. You've heard us talk about staffing data in the past, for example, and enforcement data. You've also heard us talk about ownership data, which has been newly released by CMS. They've newly released affiliate data so that you can see owners that have multiple facilities, for example, and how they all relate. But the fact of the matter is just having the data out there isn't enough. You have to be able to use it. And that's some of what we wanted to talk about today, how it can be used to protect consumers. So I'm going to turn it over to Sam, who's going to get us started with the program today. And as I said, we will go through all of the presenters and take questions at the end. So Sam, I'm going to turn it over to you.
Thank you, Lori, and hi, everyone. It's nice to be here with all of you today. I'm going to talk about something, if any of you know me, and I am, as some of you do, something that I talk about incessantly, related party transactions, and just take you through a data analysis and show, one, how accessible this data is to CMS, and two, how it could be used to not only hold facilities accountable, but also to prevent crises when facilities fail. Because unfortunately many do, and many do because of the reasons we're going to discuss today. Next slide, please. So I want to put it in the context of private equity ownership, although the problems we'll discuss today are really endemic to the whole industry. However, private equity is really an acute example of the type of behaviors we're talking about today. So I thought I would use them as an example. For those of you who don't know, private equity are investment companies, shady investment companies. Often we don't know who they are, who's investing in them, that are seeking short-term profit. Their model is to siphon out as much money from an industry within 7 years and then to move on. They have been doing this in the nursing home arena for years now and moving about. If you read the news, you'll see them. They're in hospice care and home and community-based care. Anywhere, they're like, often I compare them to sharks who smell blood. And they swoop in and unfortunately cause havoc and destruction and leave that in their wake. According to CMS, private equity owns roughly 11% of nursing homes, which is a significant amount of nursing homes. Next slide, please. Private equity means bad care, and we know this statistically. It's not something we just intuit. It's something that the evidence shows. Residents who live in private equity-owned homes experience worse outcomes. For instance, one paper in the past couple years showed that the mortality of Medicare residents rose 10% for residents in private equity-owned homes, and that is extremely troubling. CMS itself notes that this is a problem. It recently issued a rule, and part of the foundation of the rule was defining what private equity is and who, when they're involved in homes, because this is important to consumers. If you know private equity owns your home, it's probably not a good place to go. But again, I'd like to say that private equity did not create the problems. They are just exploiting them to the nth degree. Next slide, please. So I want to talk about a group called Porta Piccolo. This is a group that's become somewhat the poster child for private equity investment in nursing homes. They've been featured in major papers. There was an article in the New Yorker a couple years back showing how they swept in and destroyed probably the greatest home in Virginia in a short period of time. In 2015, when they came into this arena, the two primary people in Porto Piccolo were 25 and 32 years old. They had no experience running nursing homes. Nevertheless, in over the several years and up to now, they've acquired roughly 130 homes. And when you look at the quality of the homes, care declines significantly once the homes are purchased. They often purchase homes that are struggling or on the verge of failure, but nevertheless, the care even manages to get worse after they purchase them. Despite this, despite ample evidence that they do not provide good care, they're continued to allow purchase homes. Next slide, please. So I want to talk about. I was looking at ownership in Tennessee, and I found out, holy smokes, Porter Piccolo is in Tennessee. These two guys who live in New Jersey or New York somewhere had purchased about 12 homes in Tennessee over the past 4 to 5 years. A lot of these homes were purchased during the pandemic, and many of them are still owned by Porto Piccolo now. Next slide, please. So before I get to that, I want to give a little background. I'm going to talk about what a related party transaction is. Many of you already know this. Forgive me if you do, but it's really important and critical to the discussion. A related party transaction, well, a related party is a company that does business with a nursing home, but that company is actually owned by the nursing home owners. It's excuse me, essentially it's self-dealing. The most frequent types of these transactions are lease payments, management fees, home office costs, physical therapy. The idea being you buy a home, you sell that home to a shell company that you own, then you start charging your nursing home significant amounts of rent, hundreds of thousands, if not over $1 million a year in rent. Then you charge them management fees. Then you charge them home office costs. Then you open up a physical therapy company. And all this money is going out of the nursing home into these related party companies. And the same owners of the nursing home own the related party companies. So once that money goes into the related party, we have no idea what happens to it. So even though these are payments to the owners of the nursing home, they show up as expenses on Medicare cost reports. And that's what's critical about this, is that the more related party costs you have, the more overall costs you have, which drives down your profits. So you're able to go to your congressman and say, hey, look at my cost report. I don't have any money. My facility is losing $150,000 a year. But if you look at the related party transactions, millions oftentimes are going into those related parties. Where that goes, we have no idea. It's estimated that 75% of nursing homes use related parties. Even nonprofit homes are starting to use related party transactions. It's really a bonanza for the nursing home, particularly the for-profit industry. Roughly $11 billion goes through related party transactions each year. Next slide, please. So I just want to focus on one of these homes in Tennessee, Midtown Center in Memphis. So what I thought I'd do is, we knew when Porto Piccolo purchased the home. Why don't we look at the cost reports from the year prior to them purchasing the home, and then after they purchase it. So Midtown Center was owned by, I'm not quite sure who owned it before, but they before they sold it to Porter Piccolo, this was a cost report. If you look here, this is a related party. This is the related party sheet on a Medicare cost report. Each year, nursing homes are required to file cost reports. There's dozens and dozens of pages in it, but one page is devoted to related party transactions. By rule and by law, they have to disclose their related party transactions each year. So on this page, that's where this is done. So if you look at this form here, there was one related party transaction for this facility. It was a very typical one, a management fee. This nursing home was paying a management fee to its owners of almost $500,000. Not excusing that. Imagine if you did this over 10 homes or 12 homes or 100 homes. But here, there was only one related party transaction. This facility was paying, again, to itself, to its owners, $500,000. So let's skip to after Porter Piccolo purchased it. Next slide, please. And here it is in 2020, after Porter Piccolo purchased the home. Notice anything different? There's now the whole page is full of related party transactions. Those management fees that were $400,000 before are now $834,000. They're now paying, now they're renting that facility to themselves for $1.8 million a year. The related party transactions went from $400,000 to $5.5 million after Porter Piccolo purchased this home. Next slide. So let's look at it side by side again. That's a factor of over 10. Forgive my math if that's not correct. But you see, and this is just one home. Multiply this times 10 homes. Multiply it times 130 homes. And this is the MO for all of their homes. The money is being sucked out into these companies, and where it goes, we have no idea. Once it goes into that related party, CMS does not require or is not requiring that related party to show what they actually gave. What service did they provide for $800,000 to that facility? We just don't know. Next slide, please. And importantly, care doesn't get better. Look at staffing. This is the staffing before and after. Certainly the staffing wasn't great before, but it dropped by almost half an hour after Porter Piccolo purchased that home. Care goes down, care gets worse, and residents suffer. Next slide. And again, to reiterate, CMS has no idea where this money goes. Once I call it a black hole. It goes into the black hole and it's never seen again. CMS, it's not clear if they even look at cost reports. A colleague of mine often finds blank cost reports or cost reports with clearly incorrect information. So there's really no scrutiny on these reports. Nevertheless, CMS has the authority. It has great guidance that says, hey, these costs have to be reasonable and prudent. If these costs have to be what you would pay if you went out on the market and purchased this, not from yourself, but from someone else on the market, they have to be prudent and reasonable. And to show that they're prudent and reasonable, you need to open up your book. You need to open up your books to us so we can see that. But it's just never done. Next slide, please. So how could this data be used? In what ways could it be used? And as I indicated before, not only is it about holding them accountable and showing them that there is money, there is enough money for staff. It's just being sucked away. There is enough money for a minimum staffing standard. It's just being sucked away. It would also predict poor staffing and harm to residents. You could look at facilities where that should set up a red flag when a year after a company is owned, the related party transactions go up by a factor of 10. they could use this information to help help protect residents well before the facility fails, because these facilities fail. They go into bankruptcy and they're sold again, and the residents suffer, and many of them die, unfortunately, because of this type of practice. Next slide, please. Our solution, and many advocates who want better transparency, are calling for consolidated cost reporting. Consolidated cost reporting would require complete disclosure, not just from related parties, but from all the holding and shell companies, all the other businesses that hover around nursing homes where the money goes. That consolidated cost reporting will require disclosure from the parent company down, from the ultimate owner down to the facility. And then we would know. Then we would know if there's enough money in the system. If the nursing home industry was really really wanted to document that Medicaid doesn't pay enough or Medicare doesn't pay enough, they would embrace this. This would show once and for all how the billions and billions and billions of dollars that you and I pay in Medicare and Medicaid funds, how they are used. It's a great sanitizer, but it also allows policy choices that protect residents. It shows that there's enough money in the system. It shows that we can have a staffing mandate, and it could also ultimately lead to a requirement that a certain amount of every dollar should go to direct care. So that's my talk. We have much more information on this on our website, and I'm going to turn it over to Charlene now. Thank you.
Okay, thank you, Sam. I'm going to be reporting briefly on a new paper that Richard Malott and Robert Tyler Braun and Doug Williams and I did that just came out right during the holidays. Next slide. And it's a study of nursing home finances nationally using all the cost report data. And we wanted to look at the issue about profitability primarily, because the nursing homes have been saying they don't have their government rates, especially the Medicaid rates, are too low. They can't hire staff, there's shortages, they can't pay them more. And they claim that half of the nursing homes are facing bankruptcy and may have to close, especially the rural homes. So we selected the 2019 Medicare cost reports to examine prior to the pandemic, and because that was the most complete data at that time. So we wanted to look at three things: their revenues, their expenses, their profits and losses, the related party expenditures that Sam has been talking about, and the expenditures for direct care versus other expenditures, including profits. Next slide. We had an entire set of about 15,000 nursing homes, but we had about 12,000 nursing homes that had complete data that we could use for this study. And we looked at, first of all, the days of care. And here you see that Medicaid was 53% of days and Medicare was 11% of days. So government is paying for the majority of all the care days. Next slide. So the first thing we did is we looked at the revenues, or the income, and we looked at both their inpatient income and other income from outpatient services. So in that year, they had $126 billion in revenues. Then we wanted to look at their expenses. So they had $115 billion in expenses, and they had a total of they reported $126 billion. But so you can see that if you just look at the 126 billion, it looks like they're not making any money. So their profit margin was less than 1%. But if you look that, you see that they have $6 billion in disallowed expenses. These are expenses that the government says they're not going to pay for. They're not related to patient care costs. So nursing homes are not allowed to charge for a private jet or legal fees or association dues. And they're also supposed to pay a fair market value, as Sam said, for their related parties. So they admit to having $6 billion in disallowances. Then they also have $4 billion in depreciation. Depreciation is what they can write off on their taxes as for wear and tear on their assets. They don't necessarily have to spend that money to buy new equipment or improve the building or whatever. So when we take out the disallowances, they have a profit of almost 6%. If we take out depreciation and disallowances, it's almost 9%. And as Sam said, many nursing homes are reporting a loss. One nursing home, and this is after we cleaned the data and took outliers out. One nursing home reported a loss of 161%, and another one reported 83% profit. So there's a wide range, but nursing homes have an incentive to report losses because then they can go to government and ask for increased rates. They don't have to pay taxes and so on. Next slide. Then we wanted to look at related parties, as Sam said, and the related parties hide their profits and funnel the money away from resident care. It reduces their taxes, and very importantly, it reduces their liability. So if a patient tries to sue for poor care, the nursing home can claim they have no assets. Next slide. So what we found is that there were $11 billion in related party transactions, and that was 9.5% of their revenues. So, and 77% of nursing homes had these transactions, most all the for-profits. So this is what they admitted to, and they claim that 11 billion were allowed and 2 billion were disallowed. But because all the cost reports are just what is turned in by the facility, they do not have to be audited before they're turned in. So this is a major flaw, that CMS is not requiring audited reports. So their total disallowances and their disallowances on related party expenses may be grossly underreported. We have no way of knowing. The only way to tell what their disallowances should have been is to have an audit. And CMS rarely audits any nursing homes unless there's a complaint about fraud or suspicion of fraud. Next slide. We also wanted to look at where the money goes overall. So if we exclude their depreciation and their disallowances, only 27% of the money of every dollar they receive goes for nursing services, which I think is shockingly low. 10% goes to ancillary services, 21% goes to support services, and employee benefits are 8%. 14% goes for administration, 11% for property and other costs, and as I said, about 9% for profits. So overall, only 66% of expenditures are going for direct care, and 34% is going for administration, capital, and profits. And I think this is one of the first papers that's shown us. And I think this is why we saw that 4 states have passed direct care expenditure bills: New York, New Jersey, Pennsylvania, and Massachusetts. And these direct care expenditure bills are really an excellent idea because it sets an amount that has to be spent on direct care and limits the amount that can go for administration, property, and profits. And I think this is the only way to really bring accountability to nursing homes. And if CMS were to require greater transparency on the cost reports, audits, and accountability, we would see a lot of these bad actors get out of the nursing home business. Next slide. So I'm just going to talk about number 4 and 5. So of course, we want greater transparency on the cost reports, like how much profit is being made on the related party transactions, greater accuracy, and greater accountability with direct care spending requirements. And finally, we'd like to see the disallowances have to be returned to government. There's no reason that CMS should allow these huge companies to have what they admit to be $6 billion in disallowances. And $6 billion would more than pay for all the staffing requirements that the advocates have recommended, not the CMS staffing requirements. The CMS staffing requirements proposed would probably only be about 2.5% of revenues, and our recommendation would be about 5% of revenues. But nursing homes never admit this. They just say that this is impossible to spend more on staffing. Okay, so I'm going to stop here. Thank you. And I'm going to turn it over to Eric.
Yeah. Thanks, Charlene, and thanks all for having me here. I'm Eric Goldwine from the Long-Term Care Community Coalition, LTCCC. So, and next slide, please. The previous sections have focused a lot on the financials, related party transactions, and Charlene really teed this off nicely because she mentioned the implications in terms of direct care spending and the topic of focus for this part of the presentation, which is staffing. So I'll be expanding on payroll-based journal staffing data, also known as PBJ. Sorry for those who've not had lunch yet, but that's what it's called, PBJ, what these data mean, what they're telling us, how to find these data, and how these data can be used to protect nursing home residents. So next slide, please. So we'll start with a little PBJ 101. PBJ staffing data sets provide info on nurse and non-nurse positions for every U.S. nursing homes. Nurse positions are probably, you might be a little bit more familiar with. These include RN, LPN, CNAs, but there's also a non-nurse data set, which I recommend exploring. These include administrators, medical directors, social workers, OT, PT, you name it. These are giant mega files, like 1.3 million rows, 50 columns. They will crash your computer. These are 90 days of data for every position at just about all 15,000 nursing homes. And these data are not perfect. There's some reports of fraudulent reporting, but they are generally very good, and they're the best we have. So they're helpful in terms of helping us understand what's going on. And next slide, please. So I don't need to tell the people in this audience that staffing is critical to resident well-being. You know the studies, you know the association with staffing and less abuse, neglect, overall well-being. Better staffing saves lives, but staffing data can also save lives as well. For consumers and residents, these data can help them make informed decisions about selecting the right nursing home. Ombudsmen can use these data to evaluate the facilities in their regions. Surveyors and investigators can use these data to identify staffing levels, historical trends. You can see the staffing levels at a nursing home on a specific day. Then whether you're a policymaker, researcher, media, or advocate, there's all sorts of information out there that can help you better understand what's going on in the long-term care landscape. And next slide, please. And the good news is these data are publicly available in different forms, ranging from consumer-facing, user-friendly, to more in-the-weeds, million-row, 50-column data sets that provide information on the granular level. And we'll be going over the places you can find them, including directly on CMS for the source data, but also on Care Compare and on LTCCC's Nursing Home 411 website. The links, this slide will be shared and distributed, so you don't need to worry about copying the links. Next slide here. So this is an example of LTCCC's website where we post quarterly staffing data for every U.S. nursing home, and this includes the nurse staff and the non-nurse staff. We have total nurse staffing, we have staffing by position, so you can see a nursing home CNA staffing levels, you can see their medical director hours, you can see a number of different categories. And we also post some summary data, both at the US, the state, and the CMS regional level to give you a sense of what's going on overall. And just to give you a little taste, the PBJ data from the most recent update of Q2 2023 show that nationwide, the ratio of staffing is 3.66 hours per resident day. You might recall the number 4.1. That's the amount of time that a 2001 study showed is needed to ensure that residents receive sufficient clinical care. And you don't need a degree in advanced statistics to know that 3.66 is well below 4.1. And so understaffing is rampant. But next slide, please. If you want to see what's going on at an individual nursing home, you can use some of LTCCC's user-friendly staffing data. This is a screenshot of our national file. You would need a magnifying glass to see the numbers on this one, but this page will show you on a given nursing home its overall staffing level. You can break it down by position, you can break it down by region, by county, and you can see the overall staffing, you can see the CNA, the non-nurse, you name it. This is a user-friendly file, but it also allows you to explore on a more granular level at a specific nursing home. And we also have information on the state and the CMS regional level. The next slide will show you an example of our interactive Tableau dashboard, where again, you can see the state performances for overall staffing and for specific staffing positions. So in this case, you hover over New York and you can see that New York ranks, I think in the bottom 40, I'm zooming in here, but it ranks, I think, around 45th in the state in terms of overall staffing level. Now, on the next slide is a more, I call it a more consumer-facing option. I can't recommend Care Compare enough. This is the federal website where consumers, advocates, anyone is able to look into a specific nursing home. And you can't get every piece of data here, but you can get more than enough. You can get the overall staffing levels, you can get turnover, you can get weekend staffing levels. And then the next slide, you'll show just examples of the type of data they show. So again, total staffing, RN, LPN, nurse aide, PT, turnover, and a really cool feature that they recently added is they have comparisons to the state and US average. So you can see how, I think this is Fayette Nursing Home in Maryland, and you can see how this facility compares to the Maryland average and the national average. Next slide, please. The last data set I want to discuss is the provider info data set. This has info on staffing and other pieces of data such as surveys, ownership type, affiliated entities, and this is for every US nursing home. This is available on CMS, and we also post a more user-friendly version on the Nursing Home 411 website, where again, you can drill down by individual nursing home, by county, by region. And on the next slide, I'm just going to share a little tidbit of the type of findings that we publish. This is based on our we published this, I think, in December from some of the newest data where we find see that pie chart will show a breakdown of how many for-profit, how many nonprofit, how many government nursing homes there are, how many special focus facilities, how many one-star nursing homes there are. And then just to dig in a little deeper, one thing we looked at was abuse icon. And there's an abuse icon indicating that a facility has been cited for abuse within the last 12 months. And the nationwide rate is 8%, whereas in New York State, that's only 2.5%. And this is not to say that there's less abuse going on in New York nursing homes. It's to say that there are differences in enforcement and the likelihood of that abuse being cited. So we publish all those information. We encourage you to explore, and hopefully you'll find something that helps your advocacy or your research. Lastly, before handing it off to Anne, well, first, here's a screenshot of our provider info data set. But on our next slide, a quick note on staffing citations. We've touched on enforcement, but I think this is a telling slide here. We at LTCCC publish CMS data on health deficiencies. CMS posts detailed information on citations, including the category, which is the F tag, and the scope and severity. And I just decided to look at how often is sufficient staffing being cited. This is F725, a facility that fails to provide sufficient staff every day to meet the needs of every resident. And what I found was in the last 3 years, there's been 3,400 of these citations, which is not a lot. But of those 3,400, only 189, 6% of these were cited as causing harm. That's not a lot. I'm sure if we surveyed the people in this audience, we could come up with 200 examples of citation of insufficient staffing that cited harm. So I just want to leave on that note. Then the next slide, I'll quickly summarize our PBJ staffing data takeaways. So staffing and staffing data can protect residents. I hope I've proven that point. Unfortunately, the PBJ data show that most nursing homes are understaffed, and that understaffed nursing homes are under-enforced. Still, let's not lose all hope. These data can still inform consumers, advocates, researchers, hopefully surveyors and investigators about a nursing home's staffing levels, and hopefully, ultimately, this can lead to better enforcement and better resident outcomes. And these data are available at CMS, Care Compare, and LTCCC's Nursing Home 411. And on the next slide, if you want that data, I encourage you to spend 10 seconds, take your phone out, take a picture of that little dinosaur, and we'll be sure to email you our latest staffing reports the second they are public. So I'm going to leave it to Anne. Thank you all.
Great. All right. Well, I'll bring it home, and I'll be quick because I know some of you really have burning questions and we want to get to those. So basically, I'm going to talk a little bit about enforcement, kind of where is it? We know, obviously, we have enforcement at the state level through survey and cert programs. We know that DOJ and state attorneys general do what they can, but they actually can only tackle the worst of the worst in a very tiny percentage of that. So how about CMS? How about HHS? This is really the sort of core argument, the central argument that we're trying to leverage, and we really need your help to do that. That, you know, the kind of analysis that you've been hearing about today, which is exciting, and we hope all of you are confirmed or excited new data geeks. You can take all of this data and use it for not only analysis, but for rigorous ongoing monitoring and then for targeted enforcement. So right now, that's not really happening. Essentially, CMS's view per that second bullet is that a facility is, if it's licensed by the state, it's eligible for federal certification. And most of the enforcement recommendations come from the states. CMS doesn't often take its own initiative to come up with robust enforcement, which they could do. Not only CMPs, but denial of payments for new admissions, temporary managers. There's really quite a lot they could do that would get the attention of bad actors, which Sam talked a lot about. And there are, unfortunately, a bunch of them because this is pretty easy money to move around right now, and there's very lax enforcement. So what can we do with all this data? Well, a lot. And one of the things that we really recommend for your reading is that paper right there in the last bullet by Nina Cohn. It's right there at the link. It basically is a very good analysis, a really top-notch analysis of how CMS can use their existing authority, make some changes, and basically hold the entire sector at a national level accountable in a way that has never happened. Okay, next slide. All right, so essentially, if you have that trifecta there, analysis, monitoring, and enforcement, you can really address what we're all concerned about and have been for decades. We have long-standing trends of catastrophically poor care. We really have to stop tolerating that at the national level, and we have to take the data that we have, which is pretty exciting, on staffing, cost reports, ownership, survey insert, annual inspections, and use it to sort of put under, close ongoing scrutiny those facilities, chains, and groups that look to be harming residents. We need to prevent harm. And that's really what we're trying to get CMS to pay attention to. So we hope that we have essentially made a good case for you guys. You could profile your own states. You could profile every single facility in your own state if you want to do that, or across regions. And you will see, just like we have demonstrated here today, which chains, facilities, and private groups we should be most concerned about. Okay, next slide. All right, so the 4 streams of data that we've really been talking about here are survey insert data, payroll-based staffing data that Eric just talked about in great detail. It's exciting to see what LTCCC has done with that and made it much more accessible, really. The ownership data, along with the affiliated entities that we now have that's sitting in the PACOS database and that I think will get better. We now have the final reg out. It was overdue by 11 years. HHS dropped the ball on it, went radio silent, didn't promulgate the reg as they were supposed to do, but they finally have. That's good news. There's a good distance to go. Love your help on this to get CMS to do really good sub-regulatory guidance, to do further defining. They really didn't define in any kind of robust detail additional disclosable parties, which is the heart and soul of Section 6101 of the Affordable Care Act. That's the ownership and affiliated entities provision. So essentially, if we can get CMS and their partner DOJ to conduct the kind of oversight that we're talking about that's really needed, much more proactive, and for which there is no other substitute, then we think that CMS/HHS could become a much better, federal steward, really, of taxpayer dollars, of beneficiary quality of care and quality of life. And there are other federal agencies that do this. One of them is the Federal Aviation Administration. It's not an error-free industry, that's for sure, but the Federal Aviation Administration doesn't shy away from being really tough, from doing root cause analysis, stringent ongoing monitoring every single day, and then grounding an entire fleet if necessary. So I really like that quote from the former acting administrator. Now is the time to stare into the data and ask hard questions. Essentially, that's what we need to do in the nursing home sector and other sectors where investors have really made huge inroads, and they would like to remain invisible and out of reach forever, and we cannot afford to let that happen. Okay, next slide. All right, so I'm sure that all of you have in your head probably some pretty egregious examples of non-enforcement. This is one of them. Northview Village Nursing Home in St. Louis that closed very abruptly and moved all of their residents out overnight with only their clothes on them. They even lost one resident. I think that has finally been resolved, but it was appalling. And there's an entire provision in the Affordable Care Act, you know, I work so hard on, others out here work so hard on, that doesn't allow this. There has to be a 60-day notice. The administrator of the facility is on the hook if that notice isn't sent. And the state has to provide for relocating residents and, you know, make sure that they're all okay. None of that happened, and it's happened elsewhere. Why not? Where is the enforcement? You can see how bad, you know, just from the survey insert and other data that are available, this particular nursing home is. It should not have been any surprise that they might try and pull something like this. Question is, why were they allowed to do it? Okay, next slide. So here are our core recommendations. The provider file that Eric talked about, the affiliated ownership file, I think they're roughly the same thing that Charlene discussed, is available. Great. We have the ownership data, at least some of it. We need it to be more granular, but we have a good bit of it now. We have the PBJ data, which is really quite good. And we have survey insert data. And we can profile every single nursing home in the country. And Charlene pulled the data in descending order for the highest penalties, you know, associated with a given facility, chain, or group. And that's an obvious place, right, to focus enforcement. On cost reports, we still have a ways to go. They're not in good shape. CMS, as Sam and others said, does not audit them. They really need to start that process much more rigorously than they have, and make it clear that the kind of skimming and siphoning is not going to be tolerated. And that's the paper that Charlene talked about. It's appalling. I mean, $11 billion went out the door. Nobody can really say to exactly where it went. So we hope that we can engage you and your talents and your efforts in helping us leverage this data and getting CMS to really activate, you know, a cross-cutting task force, working group, whatever you want to call it. Perhaps work with DOJ, share data, coordinate with state officials as well, but take the lead rather than sitting back and waiting for states to, you know, do all the work effectively. We would like to see CMS become a very proactive agency. And I'll stop there, and I think it's time for questions. Thank you.
It is time for questions, and thank you to Anne, Charlene, Sam, and Eric for your excellent presentations and walking through the data, which, you know, can be a complicated topic. And I think that you explained it all really well, and we have a lot of good questions that are in here. A couple kind of broad questions, and several people have asked about, you know, like, why isn't CMS doing this already? You know, and where's Congress in this? Like, what are there any bills pending? So, do any of you want to talk about any of those issues? Anne, you talked about, you know, CMS, that we want them to, you know, take this and take the lead in looking at these and using it as a method for, and that they do have the authority to do this. So, you know, I know you addressed that, and so any of you want to address the questions related to, you know, what can we do and what else is going on out there with respect to this? So people were asking about, like, CMS, why aren't they doing this? What's happening in Congress? Is that a place where we could get some action? And are there any, like, lawsuits or any cases that are addressing this? And I think we can touch on each of those, because there are things, you know, that we can do or are happening in each of those areas. So let me turn it all to you guys first.
Well, I will just say pretty much what I indicated. I think this kind of multifactorial analysis, which is really pretty exciting. Granted, we are data geeks, so we really love it. It is fairly new insofar as it being merged and combined, but we're in an era of big data. We're in an era of, AI. And this kind of sophisticated monitoring that should flow from that kind of multifactorial analysis is something that CMS has not done before. And they have different parts of the agency that are responsible for different databases. That kind of siloization really, I think, has hampered them. But now is the time to make the case to the agency that actually you can do this, and you have a lot of enforcement authority that you're not using to make the industry pay attention. So that's what I would say.
Thanks, Anne. Anybody, Sam, or anybody want to
Well,
address legislative stuff?
and
Yeah.
many states, and this is probably discussed a bit, have tried to step up where CMS fails on the cost reports. California being one of the first passed SB 650 several years ago that require consolidated cost reports. This year is the year we'll start seeing the data from that. New Jersey's working hard to have that happen. New York and I think Pennsylvania have them now. So a lot of states are trying to get around the failure of CMS to do something. And frankly, I don't know why they don't. I think they attribute a lot of this to they haven't had a funding increase in years. But frankly, this is really low-hanging fruit. These cost reports are public knowledge. I mean, it doesn't take much to, well, you have to have certain data capabilities, but through automation and through random audits, you could at least scare nursing homes into thinking that there's going to be some accountability. And the problem is, and what's frustrating is that President Biden announced a set of reforms, and again, the staffing standard being the primary one, but a lot of it focused on ownership and transparency, and we really need to see that come through in enforcement here. So there's a lot of good things going on. There's huge initiatives, and I think momentum for transparency and ownership and finances. Just unfortunately, CMS often seems to be the caboose in the train.
Charlene, you mentioned in your presentation the direct care ratio bills that a couple states have implemented, and someone asked, like, what are the ratios that those bills have included? Do you have that right in front of you, or?
Well, the 4 states all have different ratios. New York requires 70% to be spent on direct care, and they put a limit on profits of 5%. And they were, of course, they were sued by the providers, but recently the lawsuits were dismissed. But the states are primarily focused on Medicaid, whereas we need national action on this so that all payers would be included. And I just want to mention that the providers are they have so many staff in their association. The nursing homes contribute to their associations, and they contribute a lot to Congress. And it's just hard work for advocates to try to overcome that. But that's what we have to keep doing by publicizing what's really going on.
Well, thanks, Charlene. And I think that's a good place to close for today. We are just about at the top of the hour. I think as we think about like what the options are that are available to us, this information is information we're sharing with you because we want you to be advocating for it as well. Certainly with your policymakers, with your members of Congress, you need to be asking questions. How can we be holding providers more accountable for not only the quality of care, but for the finances that they get? We want to see legislation that puts accountability in place. We want CMS to be taking action, and it can be done both at the federal level and at the state level. And as advocates, we can all be working together to achieve these goals. So thanks so much for joining us this afternoon. We'll be doing some more work on these issues going forward. As I mentioned at the beginning, the recording and the slides will be posted to the Consumer Voice website. And thank you so much to Sam, Charlene, Anne, and Eric for your excellent presentations today. Really appreciate working with all of you and having you be with us. Have a good afternoon, everyone.